to introduce Dr. Jonathan Weeks. He is the medical director of the Prenatal Addiction Program at Norton Healthcare. He is board certified in OBGYN and maternal fetal medicine. He is a fellow in the American College of OBGYN. In his past, he has served in the U.S. Navy. He has also in his past been associate professor in OBGYN Division of Maternal Fetal Medicine at the University of Louisville. And while he was there, he received multiple awards, including the Golden Apple Award and the Outstanding Faculty Education. He has also received the American College of Obstetrics Gynecology Council on Resident Education OBGYN National Faculty Award. From 2007 to 2011, he was a consultant for the OBGYN Devices Panel for the Food and Drug Administration. He's received multiple grants, including a grant to improve the quality of substance abuse treatment and prenatal care in women with narcotic addiction. He's done multiple presentations and authored papers on issues around high-risk pregnancies, and he is very well known for his work with addicted mothers. So, Dr. Weeks.
Not really? Okay. I'd like to thank Dr. Devlin, all the workers that got together to put this conference on, and certainly our sponsors for such a wonderful conference, and I'd like to thank all of you for coming. My contact information is on the screen. Feel free to track me down if you can't write that fast, and then my really valuable and esteemed team is right at that table there, so they can tell you how to find me too. I'm going to start by basically going over a few things. First, a little bit of the epidemiology of addiction in pregnancy. And secondly, we'll talk a little bit about the neurobiology. I know that probably most of you know this already, but hopefully just hearing some different words will help you share what you know with others. And then finally, we'll get into treating addiction in pregnancy, and we'll talk a little bit about the prenatal addiction program at Norton Healthcare, often referred to as the New Visions program. And if there's sufficient time, then I'll briefly discuss some challenges that we still face. As far as the epidemiology of addiction, this is an interesting slide. It's data from the National Survey on Drug Use and Health. And basically, we're looking at a time frame from about 2002 to 2013, and the percentage of individuals who are using psychotherapeutic or abusing psychotherapeutic drugs. So mostly opiates, some tranquilizers, sleeping pills. And overall, for individuals 12 years and older, this is the triangles, that's the rate over that time frame. And what's really interesting, and I'd like to bring your attention to, is this upper line. That group of patients, those patients are 18 to 25 years of age. And then finally, what I think is really fascinating, shocking, this bottom line, these are individuals who are 26 years of age or older, and above that, those are the individuals that are 12 to 17 years of age. So percentage of folks abusing psychotherapeutics in this survey, asking them if they'd abused in the last month. We can see, if you notice that previous slide, the lines were tailing down a little bit at the end, and we believe this is because there's an increasing addiction to heroin. So this pale blue area over time is heroin use, and this purple line are actual heroin overdoses. So in the time frame depicted here, about a doubling in addiction to heroin and a threefold increase in the number of overdoses related to heroin use. In Kentucky, we discussed House Bill 1, some of the changes in laws and medicine that perhaps have made prescription drugs less available, and a lot of folks believe this is what has driven the increase in heroin use. However, I'd like to point out a couple of things. Most of the national data and in Kentucky shows that there was a definite upward inflection before House Bill 1 came along. And also, if you look at CASPR, the Kentucky All Scheduled Prescription Electronic Database, Register, excuse me, these basically are total numbers of prescriptions written each year for controlled substances, all controlled substances. And what we see is In 2011, 2012, just before House Bill 1, we peaked out at about 12 million prescriptions per year in Kentucky. And by the end of 2014, we were down to just under 11 million prescriptions per year. In that time frame, only about a 10% decrease in total prescribing of controlled substances, but a much more dramatic increase in the use of heroin. So I do not believe that all of the heroin use can be explained by a reduction in available prescription drugs. We know that drug abuse, heroin addiction, opiate addiction in pregnancy is associated with a lot of adverse health consequences for a mother, and this is a neonatal abstinence syndrome conference. We also know that the baby can suffer some severe consequences. Preterm birth is increased about 2 to 3-fold if mom is abusing drugs. The same can be said for low birth weight, stillbirth rates, and of course neonatal abstinence syndrome is a tremendous problem. I'm often asked, what is it that made me decide to take an interest in this and to volunteer to see a lot of patients who are difficult to treat and very challenging. The folks who are closest to me come up and say, basically, what's wrong with you? And about 9 years ago, I was at University of Louisville covering labor and delivery and the clinic, and a resident came up to me, one of our brightest residents, just about ready to finish, and she had kind of a frowny face. Dr. Weeks, we've got this 28-year-old woman who's about 28 weeks gestation. She's just shown up. She's in acute withdrawal, and she can't stay still. We can't interview her. She just had her last baby about 1.5 years ago. She was on methadone, and she dropped out. We don't know anything about methadone. Can we call a psychiatrist and have them take her? So I sensed her frustration. It was basically like heat coming right off of her. I think my eyebrows were singed a little bit. And when I thought about it at the time, we were in a safety net hospital. I'm supposed to be a mentor, and I felt like I needed to learn more about the disease and to set a good example, because if obstetricians coming out of our training center don't feel comfortable, then no one will. So I decided to become better educated and an evangelist. About 2 years ago, I became board certified in addiction medicine. So what's wrong with those people? First of all, addiction is a developmental disorder. This is an old slide from the National Institute of Drug Abuse website. And in this particular case, they asked folks who just recently started using marijuana, and they looked at all folks who just recently started using marijuana and looked at age categories. And they basically, 67% of all the new starts for marijuana use were among youngsters aged 12 to 17. The next biggest group, about 26%, were 18 to 25 years of age. Very few started at 26 years of age or later. So definitely a developmental disease. The interesting thing is, if you look at prescription opiate abuse, more recent national surveys suggest that up to 12% of kids 12 to 17 years of age have already started abusing prescription opiates. If you look at 18 to 25, that number is over 20%. And the average age at first use of heroin is about 21 years. So this starts at a very early age. You've all heard the phrase, young, dumb, and full of substances that cloud your judgment. I heard someone laughing over there. I don't know what you're thinking, but I'm not going to say it. I'm not going to be taped saying that, because I might want to be governor one day. There are a number of factors that contribute to addiction. So most experts think that there are a variety of things that we need to become addicts. Some of it may be genetic, epigenetics, environmental, but you have to have some vulnerability, probably, a consistent exposure to drugs, over time, a change in brain mechanisms, and that's how you become an addict. It's all about the brain reward pathway, the mesolimbic dopamine system. And you'll notice, basically, it's sort of at the base of the brain in the center. We've got the ventral tegmental area, the nucleus accumbens, and the prefrontal cortex that's involved. We experience something pleasurable, dopamine levels go up in those areas. Here, again, National Institute of Drug Abuse slide. We've got, on the left, we've got a male rat in his cage, takes a jog on the wheel every now and then, but mostly it's just sort of tail gazing, because rats don't navel gaze. And after doing that for a while, he gets kind of hungry. Fortunately, researchers deliver a pizza. Rats do eat pizza. If you don't believe me, Google New York City rat carries pizza. Anybody seen that? So, pleasurable pizza meal, dopamine levels spike up by about 50%, and after a while they come back down to normal. So he's back to jogging on the wheel and navel gazing, and after a while the researchers bring him a date. He thinks that's really great because he didn't have to pay for the dinner. Woohoo! Doubling in dopamine levels. Well, that lasts for a couple of hours. So brain reward, the brain reward pathway is all about pleasure and reward. You bring in some of these pharmacological agents, methamphetamine, cocaine, morphine. You get the same effect of dopamine increase. The only thing is you might get a tenfold increase in dopamine, or depending on how much morphine you use, 200%, 250% increase in baseline dopamine levels. So much more intense pleasurable effect, and that effect is sustained instead of an hour or two, maybe 4 hours or 6 hours. Very pleasurable experience, very rewarding. The problem is, if you hammer away at these neurons with these substances frequently and with high exposure, they begin to change. There's a synaptic adaptation, and you can really think of it as a maladaptation that results in neurotransmitter dysfunction. That's what leads to the severe withdrawal symptoms when you take the drug away. That's what leads to the intense craving. There are a lot of things here that come into play. But the bottom line is you have to understand that by the time that patient shows up on labor and delivery out of control, it isn't a choice. She's harming her baby. We may be angry with her, but she is not in her right state of mind at that time. She's not as healthy as she would have been some time ago. She goes from maybe partying a little bit and liking it to can't do without it and severe withdrawal. And again, ventral tegmental area, a nucleus accumbens, prefrontal cortex. There's a complex interconnection with other neurotransmitters. We'll just talk about one, serotonin, which can affect depression and anxiety. So after a while, these patients, almost all of them are going to have depression and anxiety. So all of that dysfunction explains why when that patient shows up on your labor and delivery or visiting the baby in your nursery, they've got a lot going on with their brain that's not right. This is why when you spend a little time with them, especially when they're in withdrawal, you feel like you need to take drugs. So rather than doing that, sorry, I may have run a little bit short. Hopefully you've got these little brains on your table. And you keep that in your pocket. So when I go interview these patients that are in withdrawal, I give a few squeezes. I go in there and talk a little while, and I come out, give a few more squeezes, and sometimes I'll look at my notes to remind myself about why these patients are so hard to deal with. So how do we treat the patients? The concept of substitution and maintenance, or medication-assisted treatment, was introduced over 50 years ago by Vincent Dole and Marie Niswander in a JAMA article. They had 20-some patients they reported in the New York City area that were using heroin. They placed them on methadone, a once-a-day drug that actually produced excellent results. It prevented withdrawal symptoms, reduced cravings, blocked the euphoric effect of using other additional heroin. And today, well, really, worldwide, there have been studies questioning the value of methadone maintenance. And what's been concluded is it's clearly a savings to society over continued illicit drug use, and patients who remain in treatment for an extended period of time do much better from a medical perspective. So, one thing, when methadone came on the scene in the early 70s, it was new, the Food and Drug Administration, and physicians were very concerned about adverse effects on the fetus. And so it was actually illegal to give methadone to pregnant patients who were on heroin. So we have the experience of heroin addicts going through acute withdrawal, just acute detoxification with no assistance. And this Renteria and Weaning reported in 1973 on 46 cases, perinatal death rate, there were 6 out of 46 babies that died. Not good. And in the early 70s, Fred Zuspan, really one of the godfathers of maternal fetal medicine, did a series of amniocenteses on a patient who was on methadone and being weaned, and basically each one of these blocks, for the first 4 blocks, methadone doses were being decreased. This graph over time are epinephrine and norepinephrine levels in the amniotic fluid. And so what he found was, as you reduced mom's methadone, there was evidence of fetal stress because catecholamines in the amniotic fluid increased. These 2 early studies combined really are often referenced today as a reason not to detoxify or wean pregnant patients. Methadone maintenance has lots of benefits in pregnancy. Patients who are on methadone, increased prenatal visits, better compliance, and decreased preterm birth and IUGR. And so the American Society of Addiction Medicine, the American College of OBGYN, and others have agreed that maintenance therapy is the treatment of choice. These days, we've got a newer drug that's more commonly used, buprenorphine. Buprenorphine is a partial opiate agonist, and on this purplish table, it's a conceptual representation of how the drug works. This is a pure opiate agonist, like methadone or morphine. And as you give a greater dose, you're going to get more of a euphoric effect. With the partial opiate agonist, that happens for the first few dosage step-ups, but then you get a plateauing effect. It turns out that euphoric effect, higher euphoric effect, you could also get more respiratory depression. So that basically buprenorphine is a lot safer. The chance of overdose is less than with morphine. You still get overdoses when it's combined with other drugs and used in high doses. So it's a partial agonist. It can produce euphoria. It can precipitate withdrawal if the patient's got lots of pure opiates on board. So if they got methadone or morphine or oxycodone on board, if they've had that within 24 to 36 hours and you give them buprenorphine, you can precipitate an acute withdrawal reaction. It can be combined with naloxone, and the reason for that combination is primarily if the patient abuses, tries to inject the drug, the naloxone becomes much more bioavailable and blocks opiate receptors, whereas the buprenorphine only becomes a bit more bioavailable. So it's to deter abuse and injection. And there are a number of different brand names of the combined therapy. In pregnancy, we most often use Subutex, which is the monotherapy. This graph is, again, Casper data. So this is Kentucky data from 2009 to 2013. On a given day, the number of patients that were being treated with buprenorphine increased about tenfold in that short time frame. We had more certified providers come online and begin prescribing. With regard to pregnancy, we have the MOTHER trial, Maternal Opiate Therapy Human Experimental Research. Got to get that acronym in. The lead author was Andre Jones, a PhD, who is a prolific researcher and has published just a ton of information on opiate addiction in general and in women in particular. So they did a prospective randomized trial in the bottom line of buprenorphine versus methadone. It was double-blinded, and what they found was in the methadone group, the dropout rate during the trial was just short of 20%, whereas buprenorphine, it was about a third of patients dropped out. Neonatal abstinence syndrome rates were a bit better in the buprenorphine group. 47% of neonates had abstinence syndrome versus 57% for methadone. But more importantly, how severe was the NAS and what did it mean as far as neonatal stay? The pink to orange bars are methadone, blue is buprenorphine. And in the first, it is the mean treatment dose of morphine needed to control NAS, much lower in the buprenorphine group. And basically, hospital stay and number of days treatment in the buprenorphine group was lower. In a prospective randomized trial, fairly good numbers. I think it was 175 patients. And that really increased the enthusiasm for using buprenorphine in pregnancy. I'm going to skip that chart. So a little bit about the New Visions program. It's commonly referred to as the New Visions program at Norton Healthcare. There's the number. Basically, we have a couple of components to our prenatal addiction program. The New Visions piece, primarily, we've got staff of nursing staff that basically is the first contact for patients. They help get the patients plugged in for inpatient stabilization and later referred out to treatment. In the Maternal Fetal Medicine Center, which is basically in the same building, a few floors up, we do outpatient consultations for patients who refuse to come in and be seen as inpatients, or perhaps patients, for example, who are on maintenance medications but want more information. For example, can they wean, or are they reasonable candidates for weaning? A lot of the obstetricians are not so comfortable providing counseling about what to expect for the neonate, what to expect as far as post-operative pain management. So we do that as an outpatient in the Maternal Fetal Medicine Center, as an outpatient visit in the Maternal Fetal Medicine Center. The inpatient side, the most common scenario, most of our admissions are either patients who have an addiction issue, but they haven't plugged into prenatal care. Somehow or the other, they finally realize they need help, they call, and we will get them plugged in. Or in other cases, they may have started prenatal care, been able to conceal their addiction, but during the course of the prenatal care, the obstetrician realizes they need help. Those are the two most common scenarios. We get referrals sometimes from other addiction treatment centers who want a little bit of help stabilizing a pregnant patient. The New Visions program, I really look at it as and describe it as sort of the front door for our patients. So they actually do a lot behind the scenes that isn't really apparent to most people who are referring in. They get some basic information from the patients initially. What drugs are they abusing? They get some sense of how severe their addiction is. Do they have a past treatment history? And sort out things that may have worked relatively well or not so well. Are there barriers to treatment? No transportation, not a good support person. Location, right? So far, we've had referrals from as far away as West Virginia and Hazard, Kentucky. I think those are farthest referrals. And so obviously we're not going to bring them back every week for follow-up where we are. The New Visions program reaches out to look for follow-up in the patient's neighborhood. So all this work gets done as the patient sort of comes in the front door. Once they, when they come in, we have a number of rules. No substances for 24 hours. If we're going to use buprenorphine, we want to make sure we don't precipitate a crisis. The patient presents in admission. For admission, they should be in withdrawal. And they're assessed basically by the New Vision staff. If they truly are in withdrawal, not under the influence, then they're admitted. During their admission, they get a medical evaluation, obstetrical evaluation, and addiction treatment is initiated. Pretty comprehensive laboratory work. I think of note in particular, these days, a little bit more often, we're doing serum gabapentin levels. It turns out a lot of patients are abusing gabapentin. Sometimes they're just doing it chronically. At other times, they're trying to conceal their addiction in pregnancy, loading up on gabapentin because that doesn't show up on their obstetrician's urine toxicology screen. And as you heard, HIV and hepatitis is a big issue. TB skin testing is something to consider. And during their stay, we do an obstetrical ultrasound on every patient. We do an initial cervical length or cervical evaluation because we want to be sure the patient's not in preterm labor, and we want to assess for that. They get a clinical opiate withdrawal scale done every 4 to 6 hours during the first 2 days they're there. If they're still unstable at 48 hours, we'll continue that. But usually by then we've made some significant progress, and we know we can be pretty confident that the baby and mom are not in trouble. And we do fetal monitoring at least twice a day. Usually when they come in, we give some IV fluids for support. Diarrhea and vomiting is an issue. Dehydration because the patients don't have much of an appetite if they're in withdrawal. We add vitamins, sometimes thiamine if they've got an alcohol history. GI symptoms are treated with diarrheals and antiemetics. And we have a variety of things we use for pain, including Tylenol, a short course of ibuprofen depending on clinical circumstance. Got to be careful with that. Depends on the patient's gestational age. We won't use it if they've got oligohydramnios or preeclampsia. And for their pain, restlessness, and agitation, we'll start by using gabapentin on a PRN basis. Generally 400 milligrams about every 6 hours is how we start. If we can be reasonably sure they've not already been abusing high doses before they come in. For most patients, within the first 24 hours, we're starting Subutex. And it depends on the individual patient. If their withdrawal symptoms seem to be very severe, their admission urine toxicology screen is negative for opiates, then we're usually going to give them a 4 milligram dose pretty early on that day. And then we sort of increase we'll often give a nighttime dose to try to promote better sleep, and we will increase their dose each day according to how they respond clinically. Most of the guidelines on buprenorphine and methadone say to dose once a day. We routinely dose twice a day for buprenorphine because we want to promote sleep, or if patients are going to dose once a day, we encourage them to take it at night. Methadone we use for patients that are planning to go to a methadone treatment program after discharge. Federal law allows any practitioner in a hospital setting to give up to 72 hours if the patient is in fact going to be sent to a federally certified methadone treatment program. What about weaning and detoxification? Yes, we do provide weaning and detoxification for select patients. Shortly after I got involved at University of Louisville and started reading the literature, it became clear that by the 90s and certainly into the 2000s, there were a number of studies looking at weaning and detoxification in pregnancy that show with medical supervision and fetal assessment, there is no increased chance of fetal loss. So this was a review article that we wrote that was published in the KMA shortly after I learned all of that, and we found detoxification can be done. Rapid and slow protocols have been used, and even in the rapid protocols, as quickly as 3 days to 7 days, no evidence of increased first trimester loss or preterm birth. Some of the numbers are small. We're not so excited about doing 3-day detox. We don't do that. At the New Visions program, these numbers are a little bit old, probably 3 months behind or so. But we looked at our first just over 100 clients. We had about 21 of those who were non-compliant, and were lost to follow-up. Many of those were from distant neighborhoods, so they were stabilized in the hospital. We began stabilization. We gave bridging doses of buprenorphine, but they didn't follow up with the treatment in their neighborhood. But these are numbers for patients that we were able to get follow-up. And we had 19 patients that became abstinent after they entered New Visions, only one preterm birth, and no neonatal abstinence syndrome. There was another 7 patients, one had twins, so 8 babies, that were in the process of weaning but still on buprenorphine. The doses ranged from 2 to 4 milligrams. Again, they did very well, no preterm births, and a relatively low incidence of NAS. Another 27 patients that were on Subutex maintenance. The average dose we found in that group of patients was about 12 milligrams a day, again with excellent results. And then finally, we had about 22 moms, 23 babies that were on methadone maintenance. And the results, preterm labor higher, and NAS rates higher. This doesn't mean methadone is bad. A lot of the patients that are on methadone have much more severe addiction, polysubstance abuse, have failed other therapies, and I think it's largely a reflection of a patient who is sicker with more medical morbidity along with their addiction. And we had 8 patients who delivered during their admission. But every one of those, they sort of came in through the ER or labor and delivery in acute withdrawal at about 34 weeks gestation or beyond. And they handed the patients off to the New Visions program, and we just weren't able to catch up with them and get them stabilized. And this information, there are, again, a number of other articles, but this is something that was just published in September in the American Journal of OBGYN by a group in Tennessee, Dr. Jennifer Bell and Dr. Towers. Dr. Towers is a former mentor of mine from my fellowship days. We were both in Southern California at the time. But they looked retrospectively at 301 women who'd gone through detox or withdrawal under various circumstances, and found there were 108 who were detoxified while they were incarcerated. Interestingly they don't have a system to give opiates in the jail system. So they were using non-narcotic symptomatic relief for these patients. I think that's probably not ideal, but they had just under a 20% NAS rate. They had 23 mothers who had inpatient detox, sort of like a New Visions situation, I suppose. This was a retrospective study, so it's hard to know what care they got in the hospital. But they had intensive outpatient follow-up, and the NAS rates, again, low at 17%. 93 slow detox as an outpatient, 17% NAS rate. And here's something, though. Just detoxification alone, we're constantly telling patients that's not good enough. 77% had inpatient detox, but didn't really do much afterwards, or their follow-up wasn't very intense, and the NAS rates were very high, higher than you would certainly see if the patient was on maintenance therapy. We've learned a number of things in our program, and what I've learned is I think the patients benefit quite a bit from the expertise of a multidisciplinary team. So once they come in the hospital, they're seeing the New Vision staff. They're making contact with them by telephone initially. Once they're in the hospital, they're meeting them and talking to them every day as this group of professionals is getting them ready for their post-discharge care. We have the nursing staff on the antepartum unit have now become very, very comfortable with these patients and really, in many ways, sort of become surrogate mothers or sisters. We have our social worker who provides counseling while they're in the hospital and follow-up when they return to the maternal fetal medicine center. Our nurse practitioner sees them. I see them. On any given day, they get multiple contacts with people who are positive and who understand this is a brain disorder and who are not sort of pinging on their self-esteem. I think that makes a huge difference. Multiple visits means you're more likely to catch them when they're feeling okay. You don't make a lot of progress that first 12 hours when they're vomiting and they have diarrhea. And again, the New Visions program provides the back door for the patient. When they walk out, they literally have a paper that describes where they're going to go next. So they've got an OB appointment. We're not providing all the follow-up OB care just because I don't have the capacity to do that. But they're connected with OBs close to where they live. They've got follow-up addiction medicine appointments. And if transportation is an issue, we work through Project Link or inform them about their insurance coverage and benefits. And we also try to work on living arrangements. For the patients that are going to wean or detox, we very much like residential treatment after they leave the hospital. Not all patients are willing to do that. If they're not going to do residential, we look for reliable support persons at home, and we look at the home environment. Again, we're selective about that, but we've had good success. So what about some of the remaining challenges? As an OBGYN physician, I have a little bit different perspective than, say, the pediatric group. But I think we share this concern. What happens years down the road? Early on in my quest to become a bit better educated, I was asking, well, what's the long-term outcome from what I'm doing? And stumbled across some focus on family studies. There are a number of studies done here, but this particular focus on family study was published in 2009, and they wanted to investigate the functional resilience of children, the children of addicts. Interesting study. In the early 90s, 91 to 93, 2 methadone clinics in Seattle, Washington, the caregivers realized that most of these young patients had families, they have children, and perhaps we'll do a better job keeping them in continuous therapy if we emphasize their role as parents more, and perhaps a little less discussion about being sick as an addict. So in addition to the usual counseling and care for addiction, they added on 33 additional classes over a 2-year period of time that centered around childhood discipline, nutrition, safety in the home, a variety of family-oriented topics. They had up to 9 in-home visits, and a contingency management program where in the 2-year period, patients could earn up to $1,500 in incentives. And what they found in that study was, yes, they did gain some, they did increase the number of patients who remained in treatment continuously for at least 2 years. Not as dramatic as you would hope, but some increase. About roughly 12 years later, the researchers said, what happened to those children? So at the original study, the children were on average 8 to 10 years of age. And so about 15 years later, they found 85% of the children who were in the study. They only included the ones who were old enough to consent to be studied. 18 to 23 years of age was the age range. And they wanted to investigate functional resilience. So what they found, and this is the subgroup of kids whose parents had the benefit of the additional training while in at least 2 years of continuous medical management. They found that about 2/3, 70%, were in school and had a job. However, drug abuse free was less than 40%. Over half of the kids by 18 to 23 years of age already had a criminal record. And only about 1 in 4 were in school or had a job without a drug abuse problem and without a criminal record. So we're going to have a long-term perspective for this disease. And I am especially worried about this because we're in the midst of a huge epidemic. We've had the prescription drug abuse issue ushered in by people like myself, and now the heroin epidemic. And this would suggest that in another 10 years to 15 years or more, we're going to see another huge spike. So this is a vertically transmitted disease. We know that. I think we have to begin a much more vigorous campaign on prevention, and I think we're going to have a much broader research agenda. These patients, studies have shown, 25% of these patients have 5 or more children, and most of the pregnancies are unplanned, which means whether you're an addict or not, an unplanned pregnancy means higher chance for preterm birth, stillbirth, low birth weight. And if you look at review the literature on pregnant opiate addicts, only about 40 to 55% of them use contraception at all, and the vast majority, when they're asked, it's condoms. Very few use reliable contraception. You're down around 15% or less. In our own program, where we have close contact with these patients, we've found that only about 35% of the patients follow through with their contraception. The next thing that to think about is a lot of times, you know, in maternal fetal medicine, a lot of the most vexing problems, preterm birth, stillbirth, if you look at epidemiology and demographics, having a stable, supportive partner is protective. And if you look at statistics on marriage, especially after a few years of marriage, the chance of having a bad outcome is less. So years before I got into addiction, I have memories of sitting at my desk talking to families about their previous preterm birth or complication and all the different medical interventions and tests we can do to try to have a better outcome next time. And while I'm doing that, I'm looking across the table at the dude. It's like, you know, for addiction, yes, it's obviously about the mother. It's also a lot about the dude. And what I really want to tell the patient sometimes is, ditch the dude. Pick one of these guys, call me in 9 months. Thanks for your time and attention. I appreciate the folks who put on the program and happy to answer a few questions. Yes. Okay.
Has there been many studies on the study of Vivitrol or Camprol with these moms and the narcotic use?
Thank you for the question. Everybody heard that. Have there been any studies on Vivitrol use in pregnant patients with opiate addiction? Not many studies, no. But some studies, most of the case series data comes from Gary Hulse in Australia. Apparently there they have the long-term implants, and so they've got a program of putting long-term implants in patients, and there have been a number of patients who've become pregnant while on that, and they chose to keep their implants in, and the preliminary data shows that it's safe. Also, some women who start naltrexone during pregnancy. Again, limited studies so far. It actually is a therapy that we employ in the New Vision program for some patients. The reprotox, if you look at potential toxic effects, low risk compared to the substitution and maintenance medicines, I think the profile is favorable. There's some practical problems. It's an opiate blocker. If mom has preterm labor, needs a C-section, it's a horrendous problem to control their pain, so that we don't use it in late pregnancy. Generally, 32 weeks is about the latest, and we do a lot of surveillance to be sure that their cervix is holding up, that sort of thing. Yes?
I was wondering if you have found any benefits in slowly weaning methadone doses during pregnancy, even if it's just a couple milligrams a week. Are there improved outcomes for babies or mothers?
So methadone weaning, most of my personal experience with that has been on inpatients who have an obstetrical complication or medical complication that requires chronic hospitalization, and they're not going to go anywhere until delivery. So way back when I started this at University of Louisville, that was the first group of women we would wean. Premature rupture of membrane patients, once the membranes are ruptured, they stay until they deliver or until 34 weeks. And yes, the patients who were willing to or wanted to do that, we would wean them at a rate of 2 to 5 milligrams per week. Generally, we didn't embark on it if we couldn't make a big difference in their final dose. So if the patients, if we only have a few weeks to do it, probably not a benefit. If we have enough time, we think, to take someone from 100 milligrams to nothing, or maybe 30 milligrams or less, I believe there's a benefit. If you look at the guidance I showed you earlier from ACOG and the American Society of Addiction Medicine, the statements all say there's no relationship between methadone dose and neonatal abstinence syndrome. Some newer studies, larger numbers of patients with better control for confounders, multiple logistic regression analysis, suggest that there is a relationship. And I believe physiologically it makes no sense to say that if I give an adult 10 milligrams of methadone a day and then make them go through withdrawal 6 months later versus 100, there's a difference. And I think there is a difference in neonates, but we don't have good studies to definitively show it. I'm sorry, the other thing, by the way, is methadone, we're not a federally approved methadone site. So when patients ask me about it, I emphasize that their provider has to judge whether they're a good candidate. Many patients in methadone have more severe disease. I will send a letter to the treatment facility saying that, yes, I think it can be done safely for the fetus if they think that the patient is a reasonable candidate. Yes, I'm sorry.
Thank you, Dr. Weeks, for your military service and all that you do for our moms. I do have a question. Can we, as nurses and case managers, refer a mom directly to you, or does it have to go through the OB with an admission?
The New Visions program gets referrals from pretty much anyone. So the referrals don't have to come from an obstetrician. But we have to eventually get a hold of the patient. So we've got to deal with the patient directly. But if a relative, a friend, a caseworker, anyone says, we've got this patient who we think needs help, you can make the referral. Now, what works best is if the patient knows about it. Because if they know nothing about it, they're guarded. A lot of them, their experience is that they've been persecuted before, especially when they're pregnant. So we find we get nowhere if the patient's had no warning. When I see consults in the office, a lot of times the referral says, I want you to see the patient because she's on oxycodone or Percocet or Xanax. And when I talk to them, they have no idea why they're there, and it's hard to get someplace there. But it can come from anyone. Did I get that right, Paige? Okay.
Dr. Weeks,
Yes.
if mom does decide to detox, as peds, how long do we need to look that mom's been off drugs before we feel that the baby's safe? Generally we're watching these babies anywhere from 3 to 5 days to watch for neonatal abstinence. Is there a magic time period that if mom's off 4 weeks, 8 weeks, that we can say, oh, we can watch this child as a normal infant?
Good question. And the honest answer is, I don't know. I feel that if mom is off for 6 weeks or more, you probably could. And by the way, I didn't mention, we do witnessed urine toxicology screens for every visit, scheduled or unscheduled. And part of the counseling we give is, there are 2 reasons for this. Relapse is common, and if you relapse, we want to know early so we can reevaluate our treatment program and do a better job for you and the baby. Secondly, compliance with visits and a consistent track record of negative witnessed urine toxicology screens builds a record that you are safe, that you're well enough, and it would be very reassuring if you've got any pending CPS charges, et cetera. I think 6 weeks for sure, the baby should be okay. If you've got, negative toxicology screens, that sort of thing. How often do we do them? In the beginning, when they first leave the hospital, we're seeing them about weekly, the ones that we're following up for weaning and detoxification, because I don't like to send them out with a large number of pills. So initially, it's weekly for 2 or 3 visits. We get back the negative urine toxicology screens. Patient says they're doing well. We get the sense that they're doing well. Then we space out to 2 weeks. I never go to a month or 3 weeks. So there are lots of toxicology screens on record if we get the patient in the first trimester. Yes?
Yes, I'm from Scott County, Indiana, so we obviously have the large outbreak there and there's not many resources. So I'm just wondering what the restrictions are for your program for like our moms. What, if you accept insurance, what the costs are, transportation, things like that, because, whether we could refer to you or not.
So for the New Visions program, they have to be insured for the hospitalization piece. And other than that, they have to be willing to be seen. Some patients, when our group gets some initial information, occasionally there are patients that we don't feel are appropriate for our program. So if they've had multiple treatment failures, all the way up to, say, methadone, and all I can order is buprenorphine, and the patient doesn't want to do residential, then we're going to think twice before we take that patient in. So it's an individualized approach. But if they had multiple treatment failures, for example, never been in residential, we'll take them. And if they're willing to go into residential, we'll get them plugged in.
So, insurance, does Medicaid count as that? Or?
Yes.
Yes.
Yes. Yes.
Because nobody else does, so that's really great.
So point of clarification, yes, we do. They can come in, we'll get them stabilized, we'll do the full evaluation. Follow-up and prescribing Subutex long-term, that's sort of on an individual basis. So the ones in it, there are limited resources in Indiana for Subutex maintenance. We do take on some of those patients, but it's limited because just so much you can do with our relatively small team right now. But yeah, they can come in for Indiana Medicaid, we can get them plugged in. Yes?
The only thing that they don't take for Indiana Medicaid, you can't fill your prescriptions in our pharmacy. You cannot fill your Subutex in our pharmacy for Indiana Medicaid. That's the only drawback. They have to go back to Indiana to fill the prescriptions.
Which is not a problem. So we give them a prescription that they have to take back to Indiana to fill. Anybody in here prescribe a Subutex prescriber? Nope, okay. Oh, yes. Oh, I'm sorry.
I'm from the University of Kentucky, and we get a large referral from all of Eastern Kentucky and Central Kentucky. And one of the things that we see a lot of is the OBs are prescribing these mothers Subutex, but it doesn't appear that they're in a program, and it doesn't appear that they're going to get follow-up. And so this is one of the things we have to deal with on a daily basis. So I would appreciate any recommendations.
Yeah, that's a tough one. So I think there's good and bad there. The good is that you've got OB providers that will prescribe. The bad is no follow-up. So baby steps, if maybe you have a thought leader or someone that's kind of respected by the OB community to encourage them to at least do witnessed urine toxicology screens or a urine tox screen that has some sort of tamper-proof built in. And then the next question is, as far as counseling, if they can't do it in their own office, is there someplace else the patient can go? So when I first started at University of Louisville and got my certification for buprenorphine, we had the psychiatry department there, obviously, but they were a big catchment safety net organization. So getting the patients in for long-term psychiatric care was tough. So I worked with Project Link and referred a lot of patients to Project Link, which is mostly case management, and then small counseling in the office. I feel that it's probably better than a patient getting no care, but there are a few things, and I'd be happy if you want to send me an email. I think there are a few basic things that they can do to tighten things up. Witnessed urine toxicology screens, frequent Casper searches to be sure the patient isn't supplementing with other drugs can go a long way. And then in your area, if there is counseling available that they're just underutilizing, that might help.
My question is regarding longer-term screening of these kids and looking at how they develop. One of the less appreciated aspects of in utero opioid exposure is the impact of opioids on myelination. And a relatively cost-effective and non-invasive method of measuring the functional consequences of hypomyelination is transcranial magnetic stimulation. Is that part of the test that you apply, and are you beginning to gather data in both opioid-exposed infants and controls?
Excellent question. And no, I'm on the maternal fetal medicine side, so our neonatologists provide the long-term follow-up for the kids that end up with NAS in the nursery. And, but we're interested in this long-term follow-up. I think we definitely need it. For the past year and a half, where we've been is how to build this integrated model. Where are the holes? Because these patients, they're sick, they're not always cooperating with you, so everything finding the truth, the sorting out all the psychosocial issues, medical issues, has really consumed us so far. But I think that that long-term follow-up is critically important. And I'd love to hear more about it because, again, I am concerned that we had the prescription drug issue that really started a lot of this. Now we have Subutex providers or Buprenorphine providers, and certainly in this area, the largest number who became available were cash only, pretty much after a week or two, 30 pills at a time, high dose. I am convinced a lot of that is being diverted. When I see patients in my office and I ask them about what they're doing there on Subutex, they'll say, I'm taking 1 pill a day. But Casper says they're getting 3 a day. Yeah. And they say, well, yeah, I don't need that much. Well, where are the other 2 going? But it's an excellent question. I think we need it. I guess I need to learn more about it.
So one of your slides mentioned about taking mothers and weaning mothers off the detox program during pregnancy. There wasn't any associated fetal effects that you could tell. Besides death, how do you assess that? And how do we really know? I know ACOG doesn't support doing that because of the concerns about the impact on the fetus. I know if you talk to Lauren Jansen at Johns Hopkins, she says, well, in the middle of detox, there's a lot of autonomic instability in some of the babies. Is anyone really tracking this long term?
So I don't know that anybody, when you say tracking it long term, outcomes at 5 years of age, 7 years of age, 10 years of age. The answer would be no. And my feeling is a lot of the data that has us in the current treatment paradigm that's very rigid isn't especially good either. So, for example, when we go back to, when you look at the literature and the guidelines, and the thought leaders often reference the Rementoria Neunig study. Well, in those days, we didn't have real-time ultrasound or fetal heart rate monitoring. We have that now. There are not a lot of studies on what happens, what the changes are on non-stress tests when we're doing this to babies. But I believe as long as it is a slowly progressive wean over time, you've got fetal monitoring that does not show fetal distress. We can't evaluate myelination. But it seems implausible to me it's possible, but in the NICU, where babies are weaned over 3 weeks, there's got to be an impact there, theoretically. If we wean in utero over 6 months or 3 months, it's a concept I'm pretty comfortable with. But the long-term follow-up, no, that's not been done. The Craig Tower study I showed briefly was one of the most recent updates. And I think over 600 women, but it's all short-term NAS, preterm birth, IUGR data.
Track your relapse rates too with that? I mean, are you finding with close follow-up that you don't have a problem? People were talking about 50% relapse rates during pregnancy when this happens.
Yes, so relapse, and that's a good question. What about the people that abstinence or weaning, what is their relapse rate? We do the best we can reaching out to them, and it's something we're tracking. So our program started a little less than a year and a half ago. So we need some time. The nature of the disease, the longer you go, the harder it is to keep track of these patients. But in the beginning, we asked them to sign consents to try to gather that data. My view there is, if you look at, let's see, it's failing me right now, but there have been some systematic reviews on relapse rates, even in women who are on maintenance therapy. And by about 6 months to a year, it's 56% fall out of treatment and relapse. My personal experience when I started at University of Louisville, and sort of my thinking evolved over time for this, personal experience has been that it's at least 50% by 2 months after delivery, even in the patients who are on maintenance therapy. So it's a problem. We are offering for the patients that wean Vivitrol once the baby is out, some Vivitrol injections for another several months. Again, we only have a handful of patients right now who have started that therapy, so we're going to hopefully have some data on that in a year or two.